stress and anxiety risk are increasing. But we have still the baseline of addiction that is there from before, who can still take on their way peers by just being confined with them at home, or visiting, or taking them in a small walk. Even one-to-one walk can lead to, oh, okay, take the cigarette, or take that, or let's have smoke something. So it goes in the direction of also how the social structure is supporting or not supporting. So that's one thing that can affect the moving from the level of being at risk to the level of being part of the addiction group. As well as the availability and accessibility of services. So like in our region, I think the telemedicine and services, online health services are really limited. So if even someone feels at risk and has the conscious, or the family has the conscious, or the peers who are with them in the same place, and want to have or to reach out to support, they would not really find it. So we are in a dilemma.
That's a valid point. Thank you, because we need to come and visit this point, because Dr. Khalid mentioned a lot of statistic about the services available, and I'm really grateful to raise this point. Professor Khoja, to you.
Thank you so much, Professor Salman. This is great. I enjoy listening to you and to our respected colleagues. Assalamu alaikum, my brother, Dr. Saeed. How are you? It's great to see you in picture.
Likewise.
Really, it is a very nice presentation from both of you. I have one for you, one for Professor Carmel, and one for both of you. So, so let us start with
3 questions.
3 questions, yes. I said earlier about the role of primary care and family practice, but I would like to come again. Addiction is a worldwide societal problem, and it become very clear, as she said, Professor Carmel, it is 2 pandemics. It is becoming an issue, pandemics in every society. No society is excluded. And it's become a current problems of COVID and pandemics, and also addiction, and also a future problem. I am a person who believed on multidisciplinary approach. I could not see a movement in our region in this regard. Still, I see it is a hospital-oriented approach, and I think no country in the world can deal with addiction in this setting. So I would like you, Professor Carmen, to highlight on this issue, and if Dr. Saeed would like, it is all right. But the second question is for Dr. Saeed. What does WHO produce as a resources for proper handling of addiction during pandemics? I really, during my preparation for this webinar, I tried to see what is available for. I could not see. I mean, WHO produce a package for how to handle for SARS, for COVID, but addiction and pandemics, I could not see a very comprehensive approach in this one. Maybe I'm wrong. So I would like to have your comment. The third question for both of you: in the past, we have a concern about addiction as a societal problem for adolescent and young adult. But in real situation right now, we are seeing a real rise of addiction among older adults. And I wonder what is the driving forces for this one, and how can we, with limited resources in pandemic, to deal with older adults with young adult and adolescent of addiction. As a decision maker, it is becoming for me as a real what to do. So I need your advice. Thank you so much. These are 3 questions.
Oh, you know, I'm so happy that you mentioned the older person, because this is now also referred to as the invisible addict.
Yes.
So I will come back to this when we have a chance to unwrap that third question. But this is a whole big merging. You're absolutely right. This is a major problem that is coming. Again, another issue. So going back to the multidisciplinary, I share your philosophy because my view is I have. If you think of addiction, people often say it is a bio-psycho-social, forensic, spiritual problem. I have yet never met somebody in all my years who can deal with all of those issues. There must be the most perfect person in the world who can deal with your faith and your belief in your God at the same time, patch up your broken arm. You know, it takes everybody. That view of it takes a village to rear a child. It takes a community to look after somebody who is affected by substance use, because we know that the individual affected by substance use is you know, very nicely, we've already heard in the presentations, it's a systems issue. You have to have it as a systems issue, because the individual is only in the middle. Then if you take a kind of a ripple effect from that, out from the individual will be their immediate family, their partner, their husband, their wife, their children. Then there will be their immediate extended family. Then there will be their community, including their employer. Then there will be, and so and so. So really, it is impossible, in my view, to really have a strong model without a multidisciplinary framework. So that then means, and when we say multidisciplinary, not the classic multidisciplinary of a doctor, a nurse, a psychologist. I mean, where is the imam? Where is the priest? Where is the mother group in the leaders in the community? Where are the schools? Where are the justice? Where are the police? They all need to sit around the table to discuss the strategy. Which I think you heard a little in the framework that was described at the beginning beautifully, which picks up many of those issues implicitly, that you must have all of those disciplines available to help with articulating the solution, because everybody will be looking with a different eye. And it is in the different eye that you will hopefully get the whole. And so for me, I think it's essential that we have a multidisciplinary approach. There are some beautiful models around the world that are already been articulated. They are available. I'm sure we can give references if people would like to see, because we don't have to reinvent the wheel. People have looked at this. There is very strong evidence to support it. So I would be happy to guide people to some of those models, as I'm sure my colleagues would. Thank you.
And what's about the mature adult?
I can answer yes. I actually, the reason I'm very happy to hear that question is because you're absolutely right. When we think of substance use or problematic substance use, we think of the younger person. We think it's the teenagers rebelling, experimenting, having fun, very hedonistic. But now, if you think about the trajectory of substance use and the history of substance use, particularly illicit use, the group who maybe in the 60s, who were the young people, they are now this color and they have not necessarily matured out of their problem. So you have, there is some very nice, there's two categories, and I'm trying to remember because we ran a MOOC. I don't know if people know a MOOC, a massive open online course. And we called it Falling Down, and it was problematic substance use in older people, because they fall down as older people, maybe as a joke, but also you can fall down if you've taken drugs, but the services are falling down. And in terms of that trajectory, what we discovered is that there are people who are known as survivors. So these are people who were drug users, or people with problematic drug use, who have survived into later life, who continue to use drugs. And then there is a newer group of drug users who come to drug use later in life because of multiple bereavement or role identity crisis. So the children have left the home, they are no longer the mother. They have lost their husband, they are no longer the wife. They have lost their job because they've retired, they are no longer the boss. And all of a sudden they have a crisis in their identity. They have a lot of free time. They think, okay, maybe I'm a bit distressed. They maybe drink a little bit more. Maybe they have some money. So there is a whole array of problematic behavior that can come with the older life that nobody really has figured out. And isolation, again, we've just talked about isolation, is a big problem as well. So the issue, of course, is that we are not recognizing it because people don't ask the question, are you using substances? Are you drinking more? They don't ask it of older people because they think they are sensible. They are wise. They should know better. But people are failing to ask the question. So it's a hidden problem at the moment. And the services, yet again, are not ready, not trained, the capacity. So it's a big problem and it needs to be incorporated into any strategy. You need to think from, as we heard beautifully, in vitro, i.e. the baby who is still maybe being damaged because the mom is using drugs, to end of life, people who are taking drugs because they're miserable or something has happened that end.
And this is about reliving their good days, good life, you know, of the 60s. Yeah. You heard that, Professor Khoja, be careful. Dr. Khalid.
Thank you very much. I think it's important to highlight again, and I'll reiterate this issue, that when we are looking at substance use issues or addictive behaviors, it is like any other chronic condition. It has a multifactorial etiology. There are factors which are going to render us vulnerable, starting from the way we were brought up, our family situation, the way we were educated, the way we were socialized. That can render us vulnerable to any mental health problem, including substance use. Similarly, there would be factors which would precipitate or perpetuate the problem. But at the same time, some of those factors could be restitutional factors. So if we look at it in that broader context, and if we conceive it like that, then we will realize that there has to be action at different points by different actors. And that's what I think what Dr. Carmen was mentioning about the multidisciplinarity. It is not essentially the responsibility only of the health professionals. There would be professionals in other areas who would be better suited for certain interventions and should be the primary focus, or should be the primarily responsible for that. So that's where I think that's when I was mentioning about the framework and the evidence behind it. That's why it is important for us to recognize that health sector can play a leading role or a coordinating role, maybe, but it's not going to be responsible for delivering each and every intervention. We'll have to bring in other sectors. We'll have to make sure people are aware of their role and they are equipped to play that role. So that's one issue. And the second issue, I think, is important to realize that there are number in this region, for example, we are talking about different drugs which are coming up, some of the newer psychotropic drugs which are there. Similarly, some of the pharmaceutical, for example, medicines, which traditionally we are seeing increasingly being abused, particularly, for example, in case of women. And then we are also have to look at the fact that we have almost half of the countries in this region who were already going through difficult circumstances. They were in chronic emergencies. I mean, you look at Syria, you look at Iraq, you look at Somalia, Libya, Afghanistan, Yemen. So they're already, people are under a lot of stress because of the ongoing emergency. And at the same time, if you look at the population dynamics in this region, a very high proportion, or more than 40% of the population in majority of the countries is under 30 years of age, which are also vulnerable. But at the same time, we are also seeing that they are in countries like in the Middle East, for example, the GCC, for example, you have a very high proportion of young people who are there for work-related issues, but they are away from their normal social support structures. People from India, Pakistan, Bangladesh, Egypt, Tunisia, Lebanon, who are working there for extended periods of time. So again, they are highly vulnerable because not because because of work-related issues only, but also with the fact that social norms which are protective are not there. And that is again something which we are seeing in case, for example, in Somalia, that cut use was very common in Yemen and Somalia, but it was in a socialized manner. So there were some mechanisms to control the amount of cut which was being used in each session. But because of the breakdown of the social structures, because of the ongoing civil war and unrests going on, we are increasingly seeing that people are using cut more. They are using multiple drugs rather than just cut, or alcohol and benzodiazepines. So we also need to realize that we are in a region which is going through a period of flux. One of the things which Dr. Khoja mentioned earlier on is that we are going through a period of change anyway. For the last 30 to 40 years, there has been a very rapid social demographic change which has happened in the region. But emergencies have further worsened it, and on top of this, pandemic has come in. So this is a multi-layered problem which we need to remember, that substance use is one of the problems which is there in a plethora of problems in this region which we are facing. So consequently, we need to have that approach of multi-sectorality, collaboration and cooperation, not only within sectors, but across the borders as well. So that's one issue. The second issue, I think the specific question which Dr. Khoja was addressing to me was about the packages or guidance which is available through WHO. You might have noticed that there are, in the last few years, I think in the last 2 years actually, there are two big packages which have come out from WHO. One is on prevention standards, jointly with WHO and UNODC. And then there is the second one, the treatment standards, which has recently launched last year actually only. It's again a joint publication between WHO and UNODC on how to set up treatment services. In addition to that, we are now in the process of developing with the UNHCR this package for substance use during emergencies. So hopefully in the next few months, we will be in a position to launch that. And side by side with that is the fact that there is the minimum service package, which is currently being finalized for substance use, for mental health and substance use disorders during emergencies. So there are multiple streams of work. Some of them are available, some of them are in the process. So, and this pandemic obviously has provided fillip to all these efforts, and hopefully some good would come out of it. Over to you, Dr. Salman, Dr. Marwa.
Thank you. Professor
Thank you
Khoja,
so much.
want to come here?
Yes, thank you so much. I am very much pleased to listen to both of you, and thank you enlighten me or shed light on the available packages, guidelines from the WHO, especially in the pandemics. My question, which has come out from your discussion right now, if you look to diabetes or cardiovascular disease, whatever, there is sub-specialties going on. I mean, you will have interventional cardiology, you have electrophysiology consultant. But what about, we don't have, to my knowledge, I don't see a specialty for addiction as a sub-specialty in medical schools. I mean, if you see the Saudi Commission for Health Specialty, it is a major problem. It is, you said it's pandemic now in all globally, and in the as you mentioned, Dr. Saeed, that in the EMRO there is so many. The prevalence is high, so it's become a disease which is embedded inside the society. Why not to have specialized people in this area. They have all the skills needed, all the knowledge needed, the expertise, the know-how. Because I remember when I was in UK 30 years ago or more than that, the clinical psychologist and the social district nurse and so many people, they have special skills in dealing with these issues. What I see when I see in our hospital, Mustashfa Al-Amal Hospital, they are psychiatrists and they are given this to deal with addiction. And this is, I think, there is something missing in our workforce setup for addiction. This is my feeling. I don't know. I hope I'm wrong.
Thanks. May I respond to that?
Yeah.
So yes, I agree with you that this is an area which is relatively new. But if you look at some of the countries in this region, for example, Morocco has set up this masters and programs for addictology already. Similarly, around you, if you look at UAE, for example, in Abu Dhabi, they have set up a program for training of professionals on addiction medicine. It's already there. Iran has already started developing both for doctors and for nurses. Addiction medicine specialty is available, as is the case in Qatar and Egypt. So there are some countries which are making progress in that in the last few years. But again, it's relatively young sort of speciality in this region, most of the countries in this region. So obviously we need to do more about it. And I think I would sort of take this as an opportunity, given your relationship with the Arab Board of specialities, that this might be something worth exploring, that we need to start thinking in terms of having a more widespread and more easily accessible training programs for different professionals, be the doctors, be the social workers, be the nurses or psychologists in this particular area. So I think that might be something which we can sort of maybe work with jointly and explore going forward, because in this, I think it might be good for you to know that we are already working with the ISEM, with ISUP, and as well as the mid-career professionals in developing the core competencies for addiction professionals. So we are in the process of doing that. Hopefully in the next few months, we will have that available, and then we'll be in a position to launch this program going forward. Over to you.
Thank you. Thank you very much, Dr. Khalid.
Amazing.
And just to add, Tawfik, that there is a faculty of psychiatry of addiction, which is a part of the Royal College of Psychiatry in the UK. It existed for many, many years, by the way, and a lot of people who are interested, mainly psychiatrists, by the way. There are some people from public health as well. But on the treatment side, a lot of psychiatrists who are qualified. Similar things with nurses, they are qualified, in addiction, and they are highly qualified and well-trained. There are a lot of other elements of workforce, and I'm glad Carmel at the beginning highlighted the issue of the workforce, because sometimes it does exist, but the role is not understood fully. So that may require clarification. Let me come to services, and Dr. Khalid put a few statements which I want to stretch it a bit. I mean, we have also a question related to that. I'm sure some of these questions were from colleagues in health education. We got a number of colleagues in health education, part of the membership of our association. And you said that mass campaign, health education mass campaign, are not successful. Or at least I understood it this way. Marwa, do you think mass campaign about alcohol and drug misuse effective among young people?
Yeah, actually, it's a very valid point, and it's triggering in the young and the old, like so many thoughts about their health, especially with the current pandemic. I don't want to forget to say that there are success stories, at least among my close circle of friends and colleagues who quit some addictions during this pandemic because of the campaigns, because of the promotion ads over the different social media or even the TV for other age groups. So I think it's really important. It's part of how we reach more to the people at risk, because we shall not forget that addiction is preventable. So that's a very important message. And if we are taking it from there to the people, take care of your health, and we are there for you, and so on, and we are directing with positive messages, easy to be done. I think it's possible for at least people at risk and to not move to the next level of being in the addiction population, as well as the people who are addicts, to think or to rethink their health situation, and if they can do it and move towards a healthier lifestyle.
Carmel, we spending money, a huge amount of money on health education, of course.
Spent it together a lot of the time, a long time ago. In the European Prevention Weeks, do you remember those? Where we did all sorts of campaigns. It's an interesting question about how successful. I would not say I'm an expert, but my understanding is behavioral change, we know, is complex. It's multifactorial, and I understand that to study it, particularly in relation to campaigns and particularly anything to do with substance use behavior, is methodologically a nightmare. And that the cost to really undertake a study that would stand up to good rigor would be so expensive. I don't think anybody has probably had the money to invest in a proper longitudinal study to look at information and how it flows and how it influences behavioral change. So I think it's a very complex area to measure, and that's why we've had difficulty coming. You often see many conflicting reports and data that says, oh yes, it's successful. Others will completely say, no, it's a waste of money. And it's a very challenging one because often, in my view, it's often driven by politics as well, because it looks good to put out a campaign, just say no, blah, 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 all of this. But really, does it have the impact, and does it hit the right audience? And I think that that's difficult because we don't know enough, I think, methodologically how to measure this very, very difficult construct of behavioral change in the context of addiction, I think.
Khalid, we don't know enough. I mean, do you think all these campaigns are effective? Should we spend money? We learned from COVID about, face, hand, space. We spend millions on it, yet people are still not wearing masks, yet people don't keep that distance. They don't use sanitizers and cleaning their hands. It didn't change their behavior, unfortunately, So
I think that's something which we need to understand.
We cannot hear you, Khalid. Yeah.
I think it's important to understand, obviously, that behaviors are not linear. That you do something and something changes. We know that.
We know
that there are lots of intermediates in between, some of which are intangible and difficult to influence. But at the same time, what we need to also remember is that often when we talk about campaigns, we generally can have one-off kind of campaigns. People would have walks, would have, lots of materials available on the press or the media and so on and so forth. But it would not be, number one, sustained. And number two, it's important that when you are doing a campaign, it should be targeted. So having this kind of shotgun approach that, we just put out messages and somehow they would result in a change. That's what I mean when I say that mass media campaigns are not effective. If you are doing a targeted campaign, sustained over a period of time, clearly tailored to the needs of the audience you have identified, then yes, things would happen like we are seeing in case of tobacco, for example. There is evidence that yes, it would help. But we also need to remember that it has been going on for ages. On the other hand, I think what Carmen mentioned, that this campaign, for example, Just Say No, this during the 80s and 90s, during Reagan years, lots of money and huge amount of resources were pumped into that. Not only money, but political resources as well. And we can see where it led to. And in some cases, actually, it did more damage than actually benefit. So I think it's a complex issue. It should not be that just if we do something, there would be no consequences. There might be unintended consequences of this kind of campaigns, which we need to be aware of and we need to learn from what has happened previously. But that does not mean that we should not do anything going forward. But probably we need to be more targeted, we need to be more sustained, we need to know what the audience is, and we need to know what this audience needs and tailor our messages accordingly going forward. But not only just have messages or campaigns. It's important that if there are services that are not put into place, if the prevention services, treatment services, rehabilitation services are not put into place, having a campaign is not going to change much. You are raising the profile, you are raising the expectations. So side by side, you need to act right across the system. So that's, I think, the important thing which we need to remember. Over to you.
So is it this is begging a question now, which is, in my opinion, is very important question. And by the way, I used to tease this question, Carmen may remember, for my sin, I chaired the committee for substance misuse in Southwest London for many years. And they are all the prominent people from psychiatry, public health, general practice, medicine, nursing, all of them around the table. We discuss these issues. Is it a balance between, or a choice between war against drug, i.e. focusing on supply, or is it about harm reduction? Carmen, where are we? I'm sure you heard this question before.
It's another thorny question. I think, if you want to take a balanced view, people would argue you have to tackle both ends. You can't just allow everybody to be free to do what they want. You have anarchy, and you then don't protect members of your society. You have a duty and responsibility of care. So you can't just say legalize everything and let people make their choice. What then do you say to the 12-year-old child who's old enough to go outside the house without control or parental scrutiny and potentially be exposed to risk? So you have to look after the vulnerable in society, and we need some controls to match that. So there has to be an element of control, and there has to be legislation to do that. And I think, I don't know if we've got that right. I think people, there's swings and roundabouts. There's certainly lots of effort goes into that, and one has to hope that it has some impact. There is certainly, I think, much more humanitarian approaches to some of the control elements, where people combine control with the treatment. So you have the drug courts, we heard this, where you try and divert people away from criminality, because we know that the reason they're perhaps involved in criminality is because of their addiction. So one needs to take a very humanitarian response to that. But at the same time, we do have, unfortunately, people in the world who work on the dark side and who are there to disrupt and to make life difficult for people and to exploit. So you have to make sure that there's a measure of control on that. So that has to be part of the package. but certainly the demand reduction has to be a bigger component. You have to try and reduce the appetite. If we can address the appetite for the behavior or for the substance, then hopefully we extinguish the need for the supply. So that is where, and there is effort, and that's where we're talking this evening. How do we do that successfully within that frameworks that we've been provided with this evening, is to make sure that it is multi-sectorial, interagency, cross-border, community responses and collaboration at the international and national levels, because the demand reduction in terms of understanding treatment and making sure treatment is available. I think one of the most important points is these campaigns. Absolutely, you cannot set up expectation and say to people, please don't do this, and then not give them the tools or the resources to deal with it. So both ends are really important. If I was investing money, I would invest, because I'm a nurse, more in the health and the supply, the demand reduction and the appetite side. But I fully understand why we have to have the control element as well. So
it's the spectrum, it's the whole spectrum.
Correct.
Khalid, I'll come to this point. I mean, the point which actually, thank you very much, Carmen. It's beautiful description in terms of balancing between the two. Khalid, you said only 1/3 of the EMRO countries, i.e. probably 7, they have a harm reduction program or demand reduction program. And I have a question from one of my colleagues saying, what's about the rest?
Yeah, I mean, when I mentioned harm reduction is slightly different. I mean, demand reduction is probably a bit broader than that. Harm reduction is relatively a set of measures which are there. So, which I listed when I was mentioning, when I was showing that slide, I listed those 6-7 measures which are considered as harm reduction measures. So, like for example, needle and syringe exchange, or availability of condoms, or availability of testing for HIV and HCV, availability of ART, and so on. So, I think that is, if you look at the figures, the total package, all the services which should be part of harm reduction package are available in a very few countries.
Very few countries.
Very few countries.
So without asking which countries, how many countries they have it? You said about 1/3. What is
about 1/3? About 1/3. But again, that is a general thing which we need to remember, because when we start unpacking it and we start seeing that what's the coverage, for example, in each country, then we might find that countries which have harm reduction services available, they are not available at the national level. They might be available at a sub-national level and have limited coverage. So it is not only to say that it is available in a very few countries, but also the coverage of those services is also limited.
Could be available in the capital, but not available in other.
Yeah, maybe in a few cities, or in 10 to 15 sites across a big country of 100 million people. If you have harm reduction services available in 5 or 10 sites, that means it's accessible to a relatively small proportion of population.
But also you said, which is important, I mean, because these are generated a lot of questions, but also you said that about 50% of the those who are providing treatment, detox, they have only one drug for detox, which is, we assume, methadone or something like that.
No. What I was saying was that 50% of the case countries, one medicine for detox is available.
One drug.
One drug is available in 50% of the countries for detoxification, not even for maintenance.
Okay.
For maintenance, it's much less.
Much less.
So that's what I was highlighting, that fact.
But is this, in your professional opinion, let us take off the political hat of WHO, etc. In your professional opinion, is this big shortage in terms of services? And I think this is the question was from Professor Khoja. The website couldn't find anything, you know. Is this a huge shortage of services for the people who are actually need the services, but they cannot reach it because the drugs is not available, access point is not available, professionals are not available? I mean, this is a serious issue, is it?
Certainly. That's why I highlighted that, you know, all these facts which I was mentioning, exactly what is happening, that there is a huge treatment gap. And that's what I was highlighting, that 1 in 13 people who need treatment in countries of this region get the treatment they need, compared to 1 in 7 globally. Right? So all these factors, not having specialist services available, not having these substance use services available at primary care level, not having the medicines available for a number of reasons. Lack of medicines availability is not just because that countries do not have them. Countries simply do not procure them at all, despite the fact that they are on the essential, national essential drug list, but still, because of other reasons, nothing to do with science, methadone and buprenorphine are not procured, and they are not, the OST services are not put into place.
Is it because these methadone substitutions, some people believe it is giving them another drug? I mean,
exactly. So that's what I'm saying, that it has nothing to do with science. These are the sort of ideological, let's say, viewpoint that addiction is sort of a moral issue. It's your choice, you're doing it on your own, so why should we do something about it? And giving methadone or buprenorphine is just replacing one addiction with another, which is contrary to the evidence that if you have these people on maintenance treatment, it would not only have health benefits, but would have benefits for social services as well as for the criminal system and the justice system, etc. So I think as I said, that these are issues which are not necessarily driven by science or by evidence. These are sometimes driven by ideologies or political positions. They are there. So I think that that's where it's extremely important to, which I keep on highlighting, that substance use, until unless it is conceived as a chronic illness and is treated at par with other chronic illnesses, be they NCDs, be they mental health problems, only once we make this shift, then we will be in a position to put into place services which actually address the issue.
Professor Khoja?
Yes, thank you so much. I am pleased, Dr. Saeed, you mentioned that it's not an issue related to the science, it is other issues. But also, when I raised this issue so many times, before I came to the Gulf, then when I came to the Health Minister Council, I feel it is related to the stigma of the issue. The issue, addiction by itself is a stigma in our society globally, but in our Arab society is a stigma. This first. Second issue that is unaware of the decision maker about the real seriousness of the problem. They don't take it as a priority. They think that these people, they are anti-society, they are doing harm to the society, and so they give the least priority in their health agenda priority. What do you think? I am right or not in this issue? In this two?
Thanks, Dr. Tawfik. I think let me just go back a bit and answer it slightly indirectly, that whenever I have, and you have been there, whenever we have raised this issue at the regional committees, for example, where all the ministers of health are there from all the countries, almost invariably, we have gotten a very positive response. All the ministers of health and their teams, they are convinced that this is an important public health issue.
All right.
And often they acknowledge that yes, in their own countries, it's a problem which is getting worse, and they are worried about it. But when it comes to the interventions, that's where sometimes there is a gap between what they understand should be done and what the evidence is saying needs to be done. So that's, I think, partly that's where the professionals needs to come in and do a better job of linking and using evidence to drive the policy change which needs to happen.
Dr. Saeed, I'll give you an example. I am sorry to interrupt. Primary healthcare, they set together 30 years ago that they said it's the top priority we should apply in all over the Arab countries. And until now, only a few countries in the Arab region, they are in the EMRO applying primary healthcare. So this, we said in Arabic, قلوبنا معكم وسيوفنا مع بني أمية. Our hearts with you, but our sword with other people. This is not right. If you believe in such thing, you have to give a priority to give an action intervention. So what I am seeing really, it is from the center of my heart, I feel that they realize, everyone realize it's a great. If you see how many laws developed in the Kingdom of Saudi Arabia or in the GCC or in the Arab region to counteract the magnitude of the addiction, but it is not only bringing laws, it is also how to manage in real lives, in social, as Carmen said, social, physical, psychological, mental, beliefs, spiritual, all of these areas. It has to be whole government, whole society approach. So
we're reaching the end. We have about quick Saeed.
I fully agree with you, and I fully sort of understand your frustration and and I share with you, to be honest. But at the same time, I think we also need to remember that even if you look at the countries who say that, who agree fully that this is a public health problem, but when you look at the budgets, just look at that, where the money is going. Is it going towards health or social care, or is it going towards interdiction and police and so on and so forth? That should give you the answer where the priority lies.
I want to ask you how many countries in the region of 22 countries have actually drug court?
Just one, as far as I know.
Which one? Let us feel proud of it. Which one?
It's Iran, which has set up drug courts.
All right. Thank you very much indeed. We reached the end, and hopefully in 2 weeks' time, we have another session on a very important topic, which is the vaccination. We decided to delay it a bit, but we invited some top experts in the field to enlighten us what's going on with Pfizer, with Moderna, AstraZeneca, and the people behind these vaccines, and whether we should use it or not. Marwa, thank you very much.
Thank you very much.
Dr. Khalid, very much. Thank you. Carmel, thank you very much. On behalf of Professor Khoja and I and the Arab Public Association, thank you very much wholeheartedly. I really enjoyed the session, and you remind me of my involvement in drug misuse policy many years back. Take care. Bye-bye for now.
Thank you, everybody. Pleasure. Thank you.
Bye. Bye. Bye.
All the best. Bye-bye. Great. Thank you.